Hello everyone and welcome to today's webinar, COVID-19 EU transition and the Welsh health and social care sector. Before we get started, I would like to go over a few items so you know how to participate in today's event. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by just typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. It is now my pleasure to introduce your chair, Nesta Lloyd-Jones, Assistant Director to the Welsh NHS Confederation.
Good morning. Hope you're all well and welcome to today's webinar. Today marks 4 years since the UK voted to leave the EU, and since the referendum in 2016, most of the political space across the UK has been taken up with preparations to leave the EU. However, at the start of March, the focus quickly shifted to supporting the public health of the nation and the health and care sector throughout the COVID-19 pandemic. While nations across the world initiated lockdowns, implemented social distancing measures, and testing ramped up, the clock on the transition period continues to tick down to the deadline of 31st of December 2020. Establishing new future relationships, a UK-EU trade agreement, and a new immigration policy in 11 months was already an ambitious target, even prior to COVID-19. And the aim of today's webinar is to recap on the key issues for the EU transition for Welsh health and social care sector, to raise awareness of how COVID-19 has impacted on the UK and Welsh level decisions for EU transition, and provide an opportunity to spark questions, discussions and debate by typing in your questions to the control panel. Questions will be posed after all speakers have presented. So I'd now like to introduce you to our great speakers today. Beth Ann Bateman, the Head of Future Migration Welsh Government, Kate Ling, Senior European Policy Manager at the NHS Confederation European Team and member of the Brexit Health Alliance and Cavendish Coalition, and Professor Tamara Hervey, Professor of EU Law and University of Sheffield and Principal Investigator in Health Governance after Brexit. We will hear from each of our speakers for approximately 10 minutes on how their respective policy areas have been impacted by the international efforts to tackle COVID-19. The meeting will be held through GoToWebinar, though we will be recording the discussions and it will be made available on our YouTube channels after this event. And we'll also be sharing our speaker slides with attendees following the webinar. You can join the discussion on Twitter by using hashtag COVID-19 or EU transition, and also please tag the Welsh NHS Confederation at Welsh Confed. So without any further ado, I would now like to invite our first speaker, Beth Ann Bateman, who will be providing her perspective on the potential impact that the new points-based immigration policy could have on the Welsh health and social care workforce. So Beth Ann, over to you.
Thank you very much for inviting me to speak today. I should say that I'm part of the European team in the Welsh Government, and although I will run through the health and the social care aspects of it, I am very much a generalist in immigration, and I would expect the audience today to potentially have greater knowledge of the detail. Could I have the next slide, please? I'm sure most people are already aware that the single biggest change that will come around as a result of the end of the transition on the 31st of December is the preferential treatment of EU citizens will end and free movement will end as it's currently in retained UK legislation. What that really means is that the visa system itself, which is outlined in the 3 bullet points at the bottom of the slide, isn't one that is dramatically changed from the system that currently pertains to third country nationals who have to go through the immigration system. There are a number of small changes, or changes to the salary threshold and skills threshold, but essentially I think it's fair to say it's the same system, and a system which has attracted criticism in the past for being both expensive and a significant administrative burden both on employers and people who have to apply for visas. It's also worth adding that the main changes to the immigration system will not be made in the Immigration and Social Security Bill, but will actually be made through the immigration rules, which are quite a complex and non-transparent set of regulations, and the Home Office has accepted the Law Commission's review to simplify the rules. But I think, as Nesta's already said, time is very much against the Home Office being able to make significant changes at this point. And also I think it's worth flagging that earlier intentions to streamline the visa immigration system, potentially with the accelerated NHS visa as an exemption, seem to have been shelved. So it will very much be a kind of the system as it currently operates is likely to be what people will encounter. If I could switch to the next slide. This slide is just to illustrate that although there are a wide variety of work immigration routes into the UK, by far the greatest one is the Tier 2 general visa, which is the black line. And as you can see from the black line, there's an upward curve from 2018 when doctors and nurses were removed from the cap on numbers. And so numbers started to rise quite dramatically. And the other thing about trends at the moment, which I think is worth picking up, is that the majority of migration for work coming to the UK are now non-EU citizens. And that's the first time it's been the case since 2006. If I could have the next slide. So the current system is Tier 2 General. That's a graduate entry-level route, and as I've mentioned, there was a cap on numbers, and there was also a 30,000 salary threshold, or the 25th percentile of the occupational scale, whichever was highest. But there were exemptions for the NHS and some other public service jobs, and we would expect to see those continue. So the main changes, as I've already mentioned, will that under this route, the skills threshold will come down to NQF level 3, and the Migration Advisory Committee's call for evidence on the shortage occupation list closes tomorrow. The resident labour market test will be removed. It's not on the slide, but it's also worth recognising that the English language requirements remain the same as they did for the Tier 2 when it was a graduate level, so quite a high level of English language requirement. And the salary threshold has come down slightly. However, Maxone Modelling, when they brought out their report on the points-based system, found that around 70% of people who were previously able to enter the UK from the EU would now no longer be doing so, would not be able to do so with both the skill and the salary thresholds set where they are. I've mentioned there'll be an accelerated NHS scheme, which will operate at lower cost. Currently, we have absolutely no more detail about what that scheme will look like. And alongside that, the Prime Minister recently announced that health and social care workers will not have to pay the health surcharge, and the detail and some of the definitional issues of that is being worked through at the moment. And although the UK government refer to it being a points-based system, again, I think it's fair to say that it is the conventional employer-sponsored route which has had points added to it. If I can have the next slide. So this is what the UK government produced to give everybody a sense of how it would work. I think it's better understood as not a system where you don't count points, because actually the first 3 points on that chart are prerequisites. So in a sense, you have to have 50 points before you start. And I know that people have found it confusing. I think if you understand it as most workers will need to earn at least 25,600 in order to come into the UK. But if they have a PhD or a PhD in a STEM subject or an occupation in shortage, then they will qualify for either a 10% or a 20% salary reduction. I think that's a better way of understanding it and makes you realise that the points in some way are a kind of addition to it rather than being a fundamental part of the scheme. If I can have the next slide. As I've already mentioned, the Migration Advisory Committee are looking at what occupations ought to be at level 3 and above, and also there will be a salary reduction. But we understand the NHS public sector exemption will still apply, but it's important to note that that won't cover all posts in the NHS. And again, there's been no particular consideration of social care or for those roles that won't meet either the skill or the salary threshold, with average salaries in social care in Wales being around 17,000. That is a considerable issue. If NHS jobs are on the shortage occupation list and someone's thinking that there's no point them being there because they'll already get the public sector exemption, I think it's also worth adding that they will also qualify people for lower visa and settlement fees should they decide to settle after 5 years. And the current rate of settlement fees is about 38,000. We think the UK government have frozen those, but I still haven't seen that detail set out in legislation. And then also, as has been talked about in Wales, there is a potential for a Welsh shortage occupation list, which will enable us to put occupations in shortage in Wales, which are not in shortage in England. And as part of our response to the shortage occupation list, we've included a section arguing that social care should have special consideration within that. And the final slide, please. I just wanted to highlight a few risks and issues, and this is very much in addition to the timing one, where I think quite a lot of commentators feel that there isn't sufficient time to implement the system. It will be impossible to interpret the outcome of the policy in terms of migration to separate that from COVID and to separate it from effects around reductions in people in migration due to the economic recession that we face. And reality is, I think, that we're going to look at a period where actually most inward migration we would expect to fall quite considerably. The overall effects of the proposals will be to reduce levels of immigration, the size of the UK population and the GDP, which was based on max analysis of the introduction of the points-based system. I think that gives particular red flags to workforce issues in the future, particularly around social care and the ageing workforce. Also, a shrinking fiscal tax base as a result of lower migration will also give rise to challenges around funding public services into the future and that whole situation. And then to really say that the increase in visas has come from the non-skilled EU side. That is, once it becomes a trend again after the recession, to pick up on. But also there is concern around this model and then closing free movement. And that's to do with potentially a large amount of churn in the health and social care workforce. In 2002, people who arrived, 49% of people who arrived on a Tier 2 visa stayed for longer than 5 years, which is the point at which someone can apply for settlement. by 2014, that figure's fallen to 27%, suggesting that when people do decide to come to the UK on a visa, they're actually staying far shorter lengths of time than they used to. I'll pause there, thanks.
Great, thank you very much, Bethan. So for information, the Welsh Nhs Confederation has commissioned the Wales Centre for Public Policy to examine how future immigration policies will impact the Welsh health and care workforce, and the research will examine some of the issues and the challenges that Bethan has highlighted in her presentation, and we hope that the report will come out and be published in the autumn. So now I would like to pass on to our second speaker today, Kate Ling, who is the Senior European Policy Manager for the NHS Confederation in the European team. Kate is also a member of the Brexit Health Alliance and the Cavendish Coalition, and Kate will be discussing how future trade deals could impact on the health and social care sector more broadly. So now over to you, Kate.
Hello everyone, and thanks very much for inviting me onto this webinar, and particular thanks to Bethan, who I think has given a very helpful lead-in to what I'm proposing to say. Bethan, you were talking about the difficulty of differentiating between the impact of COVID and the impact of Brexit, and that's really the heart of what I want to talk about. So with no more ado, next slide please. Just a quick recap on what's happening at the European level. I think you will know this from the media, but just the UK has left the EU, so Brexit has happened. The transition period, during which time nothing very much is going to change, finishes on the 31st of December this year. And we know that the negotiations have got fairly stuck on some important points, particularly this issue of the level playing field, whether or not the UK continues to apply the same sort of standards in the future in all sorts of areas that the EU currently does. And I think probably the biggest overall problem from our point of view in the health and social care sector is that the UK wants to have a series of deals. There would be the potential, for example, to have a deal that would cover the issues that we're concerned about in health and social care. But the European Union is saying that they will not agree to having deals on discrete topics, that they will only agree to one whole overarching agreement. And that really is quite a big problem for us at the moment. And we're hoping that this can be unblocked in the future negotiations. There's also the very big question, of course, of the Northern Ireland Protocol and exactly how is that going to work in practice. So I think you all know what's happening now, that the Prime Minister and the European leaders met last week. The talks are going to accelerate over the next few weeks, and we're all hoping that they will be able to reach a deal by what is, I suppose, the real deadline, which is the end of October. And it may be that there'll be the possibility of some sort of fudge on phasing or the speed of implementation after the 1st of January. We don't know. Next slide, please. I've already alluded to this. The problem really for us thinking about health services is that health is not a standalone topic in the negotiations. So in other words, even if, I mean, a lot of the things that are being discussed with health in mind are actually not particularly controversial. They're things that everybody would agree on, that are motherhood and apple pie, like, you know, that we should all work together on research programs and, you know, trying to find vaccines, collaborating in all sorts of fairly uncontroversial ways. The problem is that those discussions have really got stymied in the much wider discussions, the overall shape of the agreement, and that's where the blockage is. But of course, health, which was really not, how should I put it, not a priority topic when the negotiations started, has now shot up the agenda because of the coronavirus pandemic, which in a rather peculiar way, I suppose, has done us a favour in drawing all these issues to the negotiators' attention and emphasising how important some of them are. So the pandemic has exposed the weakness of the EU-wide response, and this is not pointing the finger at any particular member state, because everybody, when it comes to a crisis, an emergency, takes all governments take the decisions that they think they need to take to protect their populations. So almost straight away, you had clampdowns, lockdowns, border controls, banning exports of medicines and medical equipment, that sort of thing, which is really what you would expect in this situation. One of the biggest problems has been that everybody is fishing in the same pond. Everyone is relying on getting, for example, personal protective equipment, ventilators, masks, gowns, etc., from the same suppliers, mostly in the Far East. So there are global supply chains there, which are very strong, but at the same time, when everybody wants to get the same items from the same source, that is obviously going to cause problems. And it makes it even more important that countries try to work together rather than competing against each other for the same scarce resources. Next slide, please. Right, how has COVID changed everything? Well, health services, not just in the UK, but certainly across Europe and further afield, are already under intense strain for all sorts of reasons to do with resourcing, funding, shortage of healthcare personnel, demographics, ageing populations, more and more pressure. And what the pandemic has done in a very unwelcome way is to expose the existing weaknesses and underfunding of health and care services, both in the 4 nations of the UK, but also further afield. COVID has made it very difficult, of course, for people to travel, so that migration has more or less stopped, and that exacerbates existing workforce shortages, particularly for countries like the UK, which depend an awful lot on people coming from overseas. And then, of course, there's the current and the delayed impact of the measures taken to try to control the pandemic, that we're expecting to see a big rise in depression and mental illness and problems because of people having lost their jobs and social connections, and also perhaps a spike in late diagnosis and treatment of other conditions which have been held up because of the pandemic. And last but not least, whatever impact Brexit may or may not have had on the UK economy, I think it will be dwarfed by the impact of coronavirus, and we see that, of course, across all countries, not just the UK. Next slide, please. From a specific UK point of view, I just said that all of these problems are shared with pretty much most other countries, but of course we have this to cope with at a particularly difficult time, because we are the only country which is actually in the middle of Brexiting, or rather we have Brexited, but we're still in the process of talks about what our future trade relationships are going to be with the EU and with other countries. So we're starting from a more difficult point than other countries, because we had already built up stockpiles. I mean, the UK has already, as you know, had 2 or 3, if you like, sort of marching up to the top of the hill, getting ready for leaving the EU. And there have been extraordinary efforts made in the health and social care system to prepare for that, building up stockpiles and making sure that transport arrangements are in place in case of any problems. But of course, those arrangements have really been quite messed up by the pandemic, and stocks that were built up have had to be used early. There's the timing, of course, the end of the transition period coinciding with winter, which is not ideal. The fact that the supplies that we normally need in the health and social care sector are exacerbated. We need more of everything, and also some different things that we may not have needed so much before. So it's basically a whole host of new problems on top of the problems that we already had. Next slide, please. Now, trade with the EU. The EU is, of course, the UK's biggest trading partner. The systems, of course, this impacts differently in Wales, because in Wales you don't have this, competitive tendering for services. But I think everything else applies pretty much across the UK, or in the case of Northern Ireland, with extra difficulties. So at the moment, there are no customs barriers, no regulatory barriers with trade between the UK and the EU. And we know that moving forward, whatever the future relationship is going to be, it will obviously be more complicated than it is now, both in terms of the movement of people, which Bethan's been talking about, supply of medicines and medical devices and other products across borders, and all sorts of other issues such as sharing data and intangible things. Next slide, please. So talking about, if you like, intangible barriers, well, not intangible, but non-tariff barriers. So it's not just a case of possibly having to levy fees on goods crossing borders, but in the case particularly of products like medicines and medical equipment, they have to adhere to very strict safety standards. And at the moment, those standards, of course, are precisely aligned with those of the EU, but in future, they will diverge. And this means that in order to be able to move goods easily across borders, that there needs to be some sort of agreement or mutual recognition of each other's regimes when it comes to manufacturing, inspection and testing medicines, and the ways in which products are authorised to be placed on the UK and EU markets, and also standards checks, for example, on livestock and foodstuffs crossing borders. Next slide. There are a whole load of issues here, and hopefully I'll be able to address some of them if people have specific questions. But border controls, the amount of border controls, of course, will depend very much on the kind of deal that is struck between the UK and the EU. The more divergences, the more complex things will be. But there will have to be some sort of border controls, and that means extra checks and paperwork. There are important issues for the UK's participation in research, so that at the moment, the UK is a very important participant in clinical trials of new treatments across the EU, but we need to adhere to the same rules as the EU countries in order to enrol patients and access data in the way that we do now. And this has implications as to the extent to which UK patients will be able to enrol in these trials in future. It's the sort of thing where you would think it was obvious that it's mutually beneficial to reach an agreement. But as I said earlier, then there may be other, if you like, political considerations that get in the way. The same goes for participation in research and other programs of science and innovation, that it seems obvious that it's beneficial to everyone, and also sharing information about health threats. So there are all sorts of systems that we currently participate in, warning each other about either sort of people or products which could be dangerous and could be crossing borders, plus of course the warning system alerting on health threats such as pandemics. And also we may not in future be able to participate in joint procurement of things like vaccines or protective personal equipment. Next slide, please. Just very quickly before I finish, what the NHS Confederation is doing about this. I'm conscious I'm speaking from a rather sort of, if you like, Anglo-centric perspective, that what I'm saying is not Wales specific, but it's worth pointing out that the Welsh Confederation is a member of the Brexit Health Alliance, which is a bringing together of patient groups, industry, the NHS, and, for example, medical royal colleges, who are calling for the most, if you like, beneficial or advantageous deal from the negotiations for the health and care sector. So that includes as much regulatory cooperation as possible, preserving reciprocal healthcare arrangements for patients, both in the UK and the EU countries, and maximum levels of research and innovation funding, for example. But that's all on our website, which I'll show on my last slide in a second. And also the Cavendish Coalition, which the Welsh Confederation is also a member of, that has been calling for a future immigration system which will meet the needs and the shortages that we're currently experiencing in the workforce in the health and care sector. And Bethan has already talked about that. So last slide, please. This is simply contact details, of course, how you can stay in touch. We issue, the NHS European Office, on behalf of the NHS Confederation, issues a Brexit bulletin, and you may also wish to look up the websites for the Brexit Health Alliance and the Cavendish Coalition, which contain a lot of up-to-date information, including we're just about to launch, hopefully in the next week or so, some specific briefing and material and publicity to do with precisely this topic on the connections between the COVID pandemic and leaving the EU. So thank you very much for listening.
Great, thank you very much, Kate. That was really, really interesting and a fantastic overview of the priorities for the NHS Confederation across Wales, but also the European office and wider. So now I would like to welcome our final speaker, Professor Tamara Hervey from Sheffield University and Principal Investigator in Health Governance after Brexit. Tamara will now focus on the EU and UK negotiation position and what they mean for health more generally, and how the current state of negotiations could impact the sector. So now I'd like to welcome Tamara.
Thank you very much. It's lovely to be able to join you on this webinar, and apologies that you can't see my face, but hopefully you can hear my voice. So I'd like to build on what the previous two speakers have said, particularly what Kate was just saying, and to share with you some of the research that's been done under a couple of projects that I'm involved in, particularly the Health Governance After Brexit project, the details of which are on this slide. If you could move to the next slide, please. And in particular, I want to share with you some analysis that's been published in record time by the journal Health Economics, Policy and Law. And this is available open access, and the link is here on the slide if you want to read it in full later on. And also some work in progress with Kate Ling and others at the NHS Confederation and Brexit Health Alliance about the position of human beings under the withdrawal agreement and what that means in particular in the context of the health and social care sector. If you could move to the next slide, please. So this is the summary of our analysis in a table form. So you can see from the colour coding in columns 2 and 7 the likely impact for aspects of the health system of different outcomes from the negotiations between the EU and the UK. So just as a starting point in terms of our analysis, previous publications showed that no form of Brexit is good for health or the NHS or social care for that matter. But some forms of Brexit are better than others. So it's worth noting that avoiding no deal at the moment that the UK left the EU is better for health and for the NHS than a no deal Brexit would have been. And that's true at this point in the Brexit process as well. An agreement will be better than no deal at the end of December. So here we can see in the first row where we're looking at the workforce position, which has already been discussed in some detail in this webinar, that it's a major negative outcome for workforce recruitment and retention, and also we can see for overall NHS financing. As Kate was saying, on many aspects relevant to health and the NHS, the two negotiating positions are relatively compatible. So if you look at the greens in column 5, that shows you where the compatibility stands and where the different types of divergence are. And as Kate has already pointed out, one of the main places that's important for health and the NHS in terms of divergence of the two negotiating positions is this matter of the level playing field in terms of broader regulation and where that broader regulation touches on the NHS and social care. So one place that it touches, which is represented on this slide, is questions of employment rights for health and care workers. So things like working time entitlements. If you could move to the next slide, please. So here we can see, thinking now about access to pharmaceuticals, vaccines, and other medical products like personal protective equipment. These are these are going to be associated with increased costs, because a free trade agreement, however close it is, involves a less close trade integration than EU membership. So we can expect increased costs to the NHS for the kinds of products that we're talking about that currently freely circulate because of our membership or previous membership of the EU during this transition period. The free trade agreement is expected to cover trade in all of these products. The UK seeks some continued shared and collaboration on technical standards on these non-tariff barriers to trade. And in this regard, the UK wants to go further than the EU in replicating the trade patterns that existed up until, and currently exist up until the end of the transition period. So one of the things that the UK is trying to do is to secure continued mutual recognition of standards, for instance, for medical devices or medical equipment. And so one of the key questions in terms of the lack of compatibility in the negotiating positions is how much agreement on non-tariff barriers will the EU accept without the UK being subject to the broader disciplines of the European Union's internal market and its law and policies. If you could move to the next slide, please. The UK is also seeking, as you can see from the bottom row here, to participate in, as a third country, in some European Union health research, although perhaps oddly, not all of it, and perhaps especially oddly, not the proposed EU for Health programme, which is to be the EU's main vehicle for its COVID response in the health domain, as opposed to in the broader economy, and indeed the EU's response to future health security matters. So it does seem a little bit odd that the UK says that it wants to collaborate with the EU in terms of health research, but it doesn't want to collaborate with the EU in terms of the EU's main research programme for responding to COVID and things like COVID into the future. Looking also at the competition and trade row, so the row just above that, and again, noting that the position in Wales is different here than the position in England, the UK's negotiating position suggests that it will be entirely outside joint procurement with the EU, as seen recently in the COVID treatment and vaccines. But the positions about procurement in the negotiating positions are fundamentally incompatible in terms of the level playing field, leading to uncertain outcomes. Whatever outcome, though, it seems clear that outside the EU, the UK's influence in securing global trade deals, or indeed contracts for medicines and equipment, is bound to be reduced. The UK as a smaller player in the global scene outside of the EU. On to the final slide now, please. In terms of regulation of biomedical research, this is particularly interesting. So despite the political rhetoric, if you dig into the legal texts, the UK is seeking, in fact, to continue mutual recognition of separate regulatory standards for clinical trials. And those regulatory standards are required in order to secure market access for medicines. So this implies, in fact, ongoing data sharing using the European Medicines Agency's systems. The European Union, by contrast, is seeking a clean break from any internal market access, including that kind of cooperation and sharing of data. Any reduced collaboration, as Kate has pointed out, in EU-UK research activity, of course, means fewer trials and means a reduction in patient access to treatments in both the UK and in the EU. So to summarise, and I'm happy to talk more about any of this in Q&A, there are mostly negative implications for the NHS and health, but they will be less, or there will be less of a negative outcome than a failure to reach an agreement at all. As we saw already, the withdrawal agreement has avoided many of the very worst aspects associated with Brexit for the NHS and social care that would have happened had there been no deal reached at the moment that the UK left the EU. And much of the withdrawal agreement has to do with protecting the rights of the people who work in the NHS, people who are EU nationals, people who work in the NHS and social care. And some of the work that we're doing with the NHS Confederation on technical legal analysis of the withdrawal agreement, for instance, pension rights of EU nationals who work in the UK, will be an important part of this context going forward. Thanks very much.
Great, thank you very much for that, and thank you to all our presenters today. Before we move on to questions, I just want to inform everybody that all the presentations will be available after today's webinar. Can people also use the chat box? We've had a couple of questions through already. So I'd like now to ask all the presenters if you can put your cameras on, that would be fantastic. So Bethan, Kate and Tamara. I know Tamara, we can't see you today, but hopefully you'll be able to hear all the questions. So the first question that's been posed is around, and I guess this is specifically for you, Bethan. Is it your view that the English language requirements are excessively high?
Yes, it would appear so, because previously they would have been designed for the graduate entry-level scheme and for that level. And for other, there are other standards, particularly for family members who accompany Tier 2 visa holders who can currently work in a variety of roles, and they have to meet a lower standard. And given that you're bringing down the skills threshold, it would have seemed logical on the face of it to also then look at the English language requirements and adjust those and possibly introduce elements of tapering that in over time.
Brilliant, thank you very much, Bethan. We've also had a question before today's webinar, and I'll ask this of you, Kate. So in regards to, in the wake of COVID-19 and a no-deal Brexit, what can and should the governments across the UK do to protect the resources and finances of the NHS?
Well, obviously we don't know what's going to happen. As Tamara said, then a deal would be much better than not concluding an agreement as a result of the current talks between the UK and the EU. And as she also said, the withdrawal agreement that's already been concluded has safeguarded some of the most important things, you know, such as the rights of UK and some of the reciprocal rights of UK and EU citizens. From the point of view of funding, the NHS, I guess I can only say that the funding situation was difficult before. There are all sorts of projections as to the impact that different kinds of Brexits might have on the economy, and of course there are political decisions that the government makes in the light of that as to how much funding to give the NHS. Already there's been a huge increase, as you know, in funding for certainly for the health sector. I wouldn't say for social care. But of course COVID will make that much more difficult. And I said in my presentation that it's, well, really, how should I put it? COVID is sort of like Brexit with bells on, if you excuse the expression, because whatever economic impact leaving the EU may have will be absolutely dwarfed, I think, by the economic impact of the measures taken to, deal with coronavirus. And those are political decisions, of course, for the government. I mean, decisions on levels of taxation and on how much of the nation's wealth to invest, in the health and social care sector.
And Kate, in regards to what you highlighted in your presentation, that health before COVID wasn't a priority, it's not a standalone topic, and it has shot up the agenda. Do you think that has reflected, or possibly will reflect, in the trade discussions and also the political discourse and in the media? Do you think, as a result of COVID, I know that Brexit Health Alliance and the Cavendish Coalition has really been pushing for health to be one of the priorities during the trade talks, but do you think as a result of COVID it is now?
Well, we certainly hope so, and I suppose it is a sort of an ill wind that blows nobody any good, in that the pandemic has really highlighted to everybody some of the issues which really were not anywhere near the top of the agenda with the negotiators before. And certainly, I mean, the Brexit Health Alliance, which, as I said, does include the Welsh Confederation, has been pushing very hard for for UK negotiators. I mean, we have a lot of contact with UK government, with the negotiators, and with politicians generally. And we believe that the things that we're asking for, which are set out very clearly on our website and in our briefings and publicity, we believe that certainly those calls have been heard. The penny has dropped, so to speak. What I didn't mention was that, I mean, clearly it takes two to tango, that we're also, if you like, working behind the scenes and working with our European counterparts, with healthcare organisations across the EU, to try to influence negotiations from the EU side as well, because patients in the EU 27 countries would also have an awful lot to lose from, if the UK and the EU fail to reach an acceptable agreement by the end of this year. So it's really important to bear that in mind, that we're not just talking about what will happen to patients in the UK, but also across the whole of Europe. And COVID has really emphasised that there are no borders where health is concerned.
Great, thank you, Kate. In regards to that question as well, Tamara, have you got a view in regards to whether the NHS or health and social care is, now a higher priority to the politicians here in the UK and in Europe?
It's interesting, isn't it? Because you would think it should be, and yet it doesn't appear to quite be joining up from my point of view. So one of the things that's really important that we mustn't lose sight of is the ability for parliaments and assemblies, so the elected bodies, to oversee what's going on. And of course, as soon as we move this to something like a trade negotiation, that's seen as a matter for government rather than a matter for elected representatives. And one of the things that has been happening in terms of the Westminster Parliament is that the European Scrutiny Committee is starting to look at, well, what do the UK negotiating positions mean and the EU negotiating positions mean in terms of things that matter to people in the UK and that they might want their MPs to be scrutinising. And the European Scrutiny Committee picked up that the health implications are a really important aspect of the negotiations. But nothing has happened with that. It hasn't been debated in Parliament. And so this is something that I think where perhaps national assemblies in the devolved nations might be able to increase pressure for there to be public oversight of what's going on.
Thank you very much, Tamara. And the questions come in for you, Bethan, following your presentation. How do you perceive the recruitment from non-EU countries will be impacted by COVID now that these countries require doctors to stay supporting them?
Well, I think overall, as I think others have said, the likely trend for most migration at the moment is downwards, while there are travel restrictions, reasons why clinicians will be required in other services. and an economic recessions which tend to dampen migration anyway. So I think the short-term answer is that, as people have already said, in migration will fall off, and depending on the length and the severity of the recession, it's not far from clear when that might pick up on. And if you are looking at immigration into the UK, questions around the attractiveness of the UK, the fees associated with the applications, and the general unfriendliness of some of the messages, granted that they're mixed, that have come out of the UK government around migration, means that I think it is likely that that there will continue to be that downward trend.
Right, thank you very much, Bethan. We've got time for one or two more questions. So, question for Tamara. How has COVID impacted the potential future relationships of the EMA and the MHRA? And Kate, you may want to come in after Tamara.
I'm not quite sure how to answer that question. I mean, COVID is a broad contextual element for everything that's going on. The desire to collaborate and cooperate was there before COVID. It should logically be there post-COVID. But the question, as Kate was saying and as I was saying, is the extent to which the European Union conceptualizes agency-level collaboration as part of the broader European internal market law discipline. Because the UK will not be subject to those disciplines. At least that's the UK's immovable position. And the EU's immovable position is, well, that means that then you can't be part of these kinds of entities like the EMA. I suppose because it could be under the political radar a bit, it might be possible to have some more deep agency collaboration than the EU has with Canada. The EMA does collaborate with Canadian equivalents. It's just it doesn't do it in a deep way, the way that it does now with the UK. I mean, to answer the question directly, I don't think COVID has a direct consequence other than reminding us that actually when it comes to developing new medicines or new vaccines, actually international cooperation and collaboration is essential, and sharing of data in ways that are comparable enhances the ability of biomedical science to understand human disease and how to treat it.
Great, thank you. Kate, is there anything that you would like to add to that?
Only that, I mean, as Tamara says, the UK is not going to be part of the European Medicines Agency. The MHRA will be developing their own procedures for authorization and marketing of medicines. I know that they will be keen to develop those, to develop wider links, perhaps outside the EU, perhaps more widely with countries like the USA or Singapore or Australia, whoever, in order to be part of a bigger market. Because I think one of the points, I think Tamara mentioned it earlier, was that the UK is obviously a fairly small market for medicines compared with the size of the EU's market, which means that companies who are developing new drugs, treatments, vaccines, etc., are likely to go to the bigger markets first, and it means that there could be delays. I mean, there is evidence that obviously blocks with like more what's the word? More sort of welly blocks who are bigger and have more influence and more buying power do tend to get medicines on the market earlier than those which don't. So that seems fairly logical, that there may be some perhaps delay in the UK accessing new treatments. It depends how good the MHRA is at striking bigger, if you like, global relationships and collaborating with other countries to have bigger buying power, I suppose. And I don't think there is a specific COVID angle to this really, except that obviously we would want to have access to any sort of vaccines or treatments as quickly as possible in future. And if those are developed in the UK, great. But if they're developed elsewhere and we have to buy them from somebody, you know, and we have to authorise them, then there could be some delays or possibly price rises as a result.
Brilliant. Thank you very much, Kate. And our hour is up after a very interesting webinar. First of all, I just want to say thank you to everyone for attending today, and especially to our three speakers, Beth Ann Bateman, Kate Ling, and Professor Tamara Obvi. As we move closer to the point where a trade deal may be agreed, the Welsh NHS Confederation will continue to highlight the potential impacts of the EU exit for health and care and for our members in Wales, the 7 health boards, 3 NHS trusts and Health Education Improvement Wales. We will also focus on what should be in place to minimise any possible disruption to patients and the medicines, technology and services that they rely on. It is integral that we are able to prepare for any outcome, particularly when the impacts could be significant, and with the healthcare system having the broader responsibility to ensure population health and well-being. As we've heard today, the coronavirus pandemic has highlighted the importance of not just maintaining but strengthening international collaboration. While negotiations are ongoing, the UK government does need to consider the needs of the health, NHS and social care in devolved nations. Wales already has a number of health and care challenges, and while also doing all it can to manage and respond to this global pandemic. Following today's webinar, please keep an eye out on a blog that we will be publishing later this week. And today's webinar is just one part of our continuing discussions on the EU transitions and its impact on the NHS in Wales. Please visit our website where there is a great deal of resources that you can help read and unwrap some of these complex issues. And if you have any questions about the transition period or any impact on yourself or service users and the professionals that you support, then please send them through to brexitfaqs@welshconfed.org. And we regularly use this questions that people send us and we update the FAQs document. When you exit the webinar today, please answer the 3 questions in the poll and how you feel the event went and also submit ideas for future events. This is the first webinar that the Welsh NHS Confederation has done, so your feedback is very welcomed. So before passing on to GoToWebinar, I just want to say thank you very much, diolch yn fawr from everybody at the Welsh NHS Confederation.
Thank you, Nesta. Thank you, everyone, again for attending to this webinar. Like Nesta just said, once you leave to this webinar, you will receive a survey on the presentation. So we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. So on behalf of the Welsh NHS Confederation and our presenters today, thank you for joining us and have a good rest of your day. Bye-bye.
Thank you very much.